being experienced. So this biomedical intervention was adopted by WHO in the year 2015, and Kenya rolled it out from the year 2016. And we've had to gather some experiences or feedback from that implementation. And the various challenges have informed this study in terms of approaches. And the various regimens recommended for this include the fixed dose combinations of tenofovir and emtricitabine. We also have lamivudine plus tenofovir, as well as you can also use tenofovir alone. And these are mainly pills taken daily. It's a single pill, but taken daily to prevent HIV infection. So again, as we roll out PrEP, what are the challenges which are still being experienced? We know that HIV is still a very stigmatizing disease. And within the public health facility, you find that PrEP as well is provided within the same HIV clinics. And this brings some challenges because being a stigmatized disease, there is a reluctance for those seeking PrEP services to as well seek these services within the HIV clinic setup. And we also know that most of these public health facilities which offer HIV services have limited hours of operation. And also there is what we call the long times and travel distance, depending on where the facility is located. Sometimes you go to these sites, they are congested, and also they are limited in terms of where you can access. So not all HIV clinics necessarily provide PrEP. And also there's some kind of lack of privacy where the clinics are found to be overcrowded. So with these challenges in mind, then what differentiated service delivery model is needed to overcome the challenges? So there are various approaches in which this can be redefined. Because we know, even with the HIV clinic, we started with clients coming almost every week for their treatment or monthly, to now even having longer return periods of even up to 6 months. But currently we know for PrEP, you have to come for your refills and testing almost on a monthly basis. So how can that be remodified and still be able to achieve the desired outcome? We also know in terms of entry into PrEP, you have to undergo HIV testing. And this testing has to be conducted either by a counselor or a health worker before initiating onto PrEP. Is there a way we can differentiate that model, for example, to go into what we refer currently as blood-based HIV self-testing, where a client, just the same way you probably test for blood sugar or maybe pregnancy test, can you also just undertake your own HIV test and that test be actually, the result be used as a precursor to entry into PrEP? So all those are some of the considerations which are being provided. And even in terms of location, we have said now mainly you have to go to a public health clinic to access these services. And we know by the nature of the intervention, the access to those public facilities sometimes can be a challenge. So which other service locations can this be availed beyond the public HIV clinic? And that's why we are saying private pharmacies or the community pharmacies, can we even have the option of telemedicine to have actually access the same service? So let's go to the next slide. Yeah. So what is the potential for this pharmacy-based PrEP delivery? I think this cannot be re-emphasized further, because we know very well that within our setup, mostly the first call for seeking healthcare services has been defined to be the community pharmacy. And there are studies to show that, and there is evidence to actually support that. And unfortunately, even as per the current definition of a service delivery point, a pharmacy is not considered a service delivery point. I don't know whether some of you know that. Even the Ministry of Health is not officially recognized that a pharmacy can provide a healthcare service. I think it is more or less seen as a business rather than a service delivery care, especially for the private pharmacies. So if you go to for example, Kenya Master Health Facility List, you will not find there any pharmacy registered and listed as a delivery point for health services. And I think that's one of the major policy gaps we have, and which we actually need to re-engineer, especially through the pharmacy practice bill. So we need to define our pharmacies, our community pharmacies, as a service point to access services, and define what kind of services can be accessed. And we know very well that the number of those community pharmacies are quite a number. So this pharmacy-based PrEP delivery can also provide urgent and preventive care needs, especially for blood pressure testing, sexually transmitted illness treatment. And fun enough, we know very well that even where services are offered for free in our public health facilities, we still have parts of our population who are able to access their health services from a pharmacy at a fee. So why can't we as well increase this access to various health services? And we just saw on day one that even family planning can be accessed from this point. So it's just a matter of increasing and defining further the kind of services a pharmacy can provide. The other point is, as we roll out some of these services, the Ministry of Health and other stakeholders, and even the World Health Organization, has actually identified some services which can be provided within a pharmacy setting. And although, of course, we still need a lot of implementation science evidence to then inform policy change. So towards this, there was some stakeholders' involvement in the year 2020. And the entry point for PrEP is the National AIDS and STIs Control Program, being that HIV is managed within this unit or division within the ministry. We also had the Pharmacy and Poisons Board, KEMSA, the Pharmacy Association, as well as the Pharmaceutical Society of Kenya, the technologists, the medical practitioners and dentists council, as well as CHAI as an implementing partner. So all those who are informed, and the issue was, do we have a local generated evidence towards availing PrEP pharmacies within Kenya? And I think this is a study which was presented sometime in the last conference, where I think some years back. So this study was conducted in two counties, that is Kiambu and Kisumu County, where it just involved in each of those counties there were two pharmacies involved, and where PrEP was offered to clients aged 18 years and above, and who met the eligibility criteria for PrEP prescribing checklist. And the recruitment was mainly in terms of posters, pharmacy providers, and word of mouth. However, the study involved a small fee of about Kenya shillings 300 before the clients could provide their services. So from this study, which took about 1 year, the most interesting bit was the demographics of the persons who are getting services from these settings, and also the type of risks. And as per this risk screening tool, majority of the clients who accessed PrEP from the pharmacies were those with partners of unknown HIV status, followed by inconsistency in condom use, as well as the least being the injecting drug users who are sharing needles. And these are some of the risks which persons are exposed to, yet they engage in unprotected sex. And by taking this single pill daily, they're able to prevent themselves from HIV infection. So the overall findings from that pilot study compared to the standard of care, this is where already services were being provided within public HIV clinics. It was very clear that majority of the people who now sought services within a pharmacy were mainly male compared to those who accessed services from HIV clinics. In terms of age, the majority of clients who accessed pharmacy, PrEP in pharmacy, were mainly those aged below 25 years. And in terms of risk behaviors, again, the issue of unknown HIV status featured highly as compared to other risky behaviors. And because of now the issue of challenges in continuation, because we know that once you initiate on PrEP, then you need to still remain on PrEP for it to still take effect. So the continuation rates became lower and lower as time went by, from month 1 compared to month 4 and 7. So the rates of continuations decreased with the period on PrEP. So what are some of the challenges and opportunities which were found within this approach? So some of the clients noted concern about the cost of access. So they perceived that that fee of Kenya shillings 300 was expensive to them. Some also said, in terms of HIV screening, because before you get onto PrEP, you need to undergo risk assessment. So they found that it was a time-consuming experience, and some clients were uncomfortable doing it aloud. And then some were uncomfortable testing for HIV within the pharmacy setting, especially if they were unsure of their status, and if they were actually testing for the first time. So with that, then there was need to do some improvements for this model, and hence the need for an extended pilot. So this extended pilot is funded as well under the Bill and Melinda Gates Foundation, where we seek to have more implementation evidence on whether this approach can work. And apart from offering PrEP in a brick and mortar setting, there is a proposal to actually pilot an online model PrEP delivery in partnership with Maidawa. And that is something which is in the pipeline to generate additional evidence. So for the brick and mortar extended pilot, this was already started in February this year. And so far, these are the preliminary findings where the number of clients initiated as of May 2022 were about 568. And apart from actually giving PrEP, within this setting, clients also access PEP. And PEP has been seen as a bridge to PrEP. So most clients who are actually seeking PEP services, that is the post-exposure prophylaxis, eventually agree to transition to PrEP. Because instead of always taking the prophylaxis after exposure, then they accepted to actually take the pill before exposure. And again, with this approach, you can see from the figures or the data is that we have 46% of them being male and about 46% being aged below 25 years and 77% being unmarried. And in terms of risky behavior, again, in this case, inconsistent condom use is the most cited reason for seeking PrEP services, followed by partners of unknown HIV status, with the least being a partner living with HIV, in what we mainly refer to as serodiscordant relationships. In terms of PEP, we've not analyzed the risky behaviors. So this is additional findings in terms of PEP to PrEP transitions, where, as I had said, clients who are continuously seeking PEP services are actually advised to transition to PrEP. And the transition rate currently is about 23%. And because the study is ongoing, we'll be able to give final findings on what is the overall transition of PrEP to PEP. So again, beyond this study, we'll now get to cluster randomized controlled trials of additional pharmacies. So currently the study is being conducted within 12 pharmacies. It's going to extend to 60, and this is going to consider other bases, whether in terms of fee or not, no fee charged. Time, huh? Okay. So I think in a nutshell, what I'll say is, as pharmacists, we probably have lots of opportunities, and I think there is what we call a policy window on how we can expand the set of services which we need to offer, especially within community pharmacies. And this needs to be packaged, and especially within the pharmacy practice bill, so that we continually expand the role of community pharmacies. It's already happening, but it's not officially recognized. So I think this is a challenge to us as PSK and also through the practice committee. Thank you.
Thank you so much, Dr. Micah. That was a very, very good presentation. We are going to take questions. Write them down on a piece of paper. After the abstract presentations, we're going to take all the questions together. I want to quickly invite Dr. Mary Sang to make her presentation, and Dr. Eric just to come and submit the presentation. Dr. Mary.
Good morning, everyone. My name is Mary Sang. I'm the Monitoring and Evaluation Officer in Baringo County. So my presentation is about telemedicine, how we are implementing it in Baringo. It's a new project. So just wait for the slides a bit.
Good morning. Okay, it's now morning. So good morning. Okay, those people at the back there. Good morning. Thank you. We are running way behind schedule, and so we're going to try to play catch up. And as you know, it will be a difficult task because tomorrow we are not here. So we have a preliminary order, subject to change as well, but this is the preliminary order we are going to follow. Mary Sang, who is already here, then will be Eric after that. After that will be Dr. Jane Wasiga, and then we'll have Professor Ndemo and Professor Claire, and then we'll have the panel discussion with Mike Mungoma and MOH and JPHIGO. Yeah, that. So that's the order we will follow, and then we'll go to the sponsor's address, and we are going to do half-time. So if your address was half an hour, you'll now have 15 minutes. If you had 10 minutes, you'll have 5 minutes. So everybody knows how to divide by 2, so I don't need to go on further, but that's it. And then yesterday, my good friend was ringing the bell, but nobody knew what it was for. You thought it was somebody's ringtone. So, Catherine, can you play that so that they all hear? Okay, that doesn't mean now you have another 5 minutes. It means time is up. So let's just know that when that bell goes, time is up, and you say thank you very much for listening to me, and we can go on. Are we ready?
Yes, we're ready.
All right, thank you so much.
Yeah, so this project, like had earlier explained, is it's dubbed Dr. Smart. It's being implemented in 4 counties. Apart from Baringo, it's also being implemented in Lamu, in Samburu, and in Homa Bay. And the target is about 32,000 children. In Baringo alone, we are targeting about 5,400. So what really is telemedicine? It's remote diagnosis and treatment of patients by means of telecommunications technology. And this makes it possible for a doctor to treat a patient from a distance. So it's now possible for patients who are living in remote areas to benefit from from specialists stationed at Gertrude's. So our partner here is Gertrude's Hospital. That's where the subspecialists are, and that our children from Chemolingot Sub-County Hospital in Tiati in Baringo benefit. So the program is targeting that number of children, 5,400. So we're targeting about 150 children per month. The age group is not the children we think of per se, but actually up to 21 years. This is just to widen the scope of those who can benefit. There's a screening criteria, of course, for patients to qualify to see the specialist. So for those who have like complicated cases are the ones who would benefit. Subspecializations, there are many, actually, about 17, but just to mention a few, there are oncologists, endocrinologists, neurosurgeons, and dermatologists, among others, depending on now the specialty that the child would need to benefit from. Next. So the goals are really to offer timely specialist pediatric services through telemedicine. These are to children living in rural or underserved areas. This is to improve the capacity of health workers also so that they can correctly diagnose and treat these children and correctly link those who require now advanced specialist care. So we also, one of the aims of the project is also to improve capacity of community health volunteers or CHVs to provide community education in child health. And then the activities include, we requested support. So this has been funded largely by Gertrude's Hospital Foundation as well as M-Pesa Foundation. And like I said, so the clinician is with the patient in Chemolingot, but the specialist at Gertrude's is able to examine this patient remotely and now provide the continuum of care. So far, we've only been able to see about, by the time I was writing the abstract, about 50 children, but as we are speaking now, we've reached about 100 children. Next. So this was the commissioning of the equipment in November of last year. This is our Excellency, His Excellency the Governor, together with bosses from M-Pesa and Gertrude's Hospital. Next. Yeah, this is one of the clinicians seeing a patient, and the specialist at Gertrude is able to do exactly, to view all this through the equipment. This is a photo of the equipment. And so what have we learned? It's true that telemedicine has provided access to specialized care to people in remote areas. This saves travel time, money, and everything. So diagnosis and management is timely, and also information sharing among doctors is easier. But some of the drawbacks include reduced privacy issues and occasional technical hitches because of the equipment hanging sometimes, and network challenges in the remote areas of Tiati. Yeah, this is just the presentation. It was shown on NTV as a feature. Next. Yeah, so I just want to acknowledge my co-author. She's called Dr. Elizabeth. She's a medical superintendent of Sub-County Hospital Chemolingot, and the specialists as well as M-Pesa Foundation staff. Thank you.
Thank you so much. Next time we'll do her presentation by telemedicine. So she doesn't need to be here. We'll just see her on the screen from Baringo Sub-County. Great, we're moving on swiftly. So our next presenter is Dr. Eric Moringo. Are you ready, Eric? Please come. And in case you missed the announcement, you only have 10 minutes.
Thank you, Dr. Anis. Let me time myself so that we don't start ringing bells when it's not time. Delegates of the conference, thank you for the opportunity to present in the 42nd PSK Annual Conference. The paper was about, I use this one. I'm too tall.
Sound check, 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 check.
Yeah. This is a paper that we did last year. It's in the process, the final stages of being uploaded to the Antibiotics Journal. It was exploring the antimicrobial stewardship educational needs of healthcare students. I use this. Exploring education needs of healthcare students in select African countries, Kenya included, and the potential use of an antimicrobial prescribing app. So these are colleagues from all over Africa. We have Nigeria, Uganda, Ghana. I was from Kenya. Then lead researchers, Victoria Ruta, who is the CEO of Commonwealth Pharmacists Association, and Diana Shiro, the head of the project. So Commonwealth Partnership, which is the project, is a UK-funded Fleming fund since 2018. It's managed by Commonwealth Pharmacists Association and Tropical Health and Education. Tropical Health and Education, what is the T? I don't remember the T. Trust, yes, thank you. So launched in 4 different African countries, Kenya, Uganda, Uganda, Zambia, and Tanzania. Then Kenya came as part of an extension program, and the aim of the application was to provide easy access to infection management resources and improve antimicrobial steward prescribing. So the study, we conducted it to assess student educational needs and evaluate knowledge and attitudes of healthcare students towards antimicrobial stewardship. So it was a survey, a 59-item questionnaire. The format we used were choice format, true or false, or the Likert, where there are varying degrees of agreement or disagreement. It was piloted with 17 healthcare students in Nigeria and Uganda. Then the target countries is Kenya included. I think that's the most important thing, is that Kenya was included in the survey. So this is how we received the survey between April and May. I am the representative for Kenya, so I disseminated to the Kenyan students. I am also the patron of Kenya Pharmacy Students Association, so it was easier for me. Analysis was by SPSS and Excel. So the results of the survey is this. Pharmacy students who participated, which is the most important for our case, it's 250, which is it's actually 50 plus 1, 1.8, 50 plus 1. Yeah. The other disciplines involved were, as you can see, and most of them, they were the upper years of study, so from 3rd year to 5 years, and maybe 6 for the medicine students. So Kenya, the participation was 111, which is 20.1% of the whole respondents. So these are some of the questions that were presented. When you ask a student, have you been taught on prudent use of antibiotics? Those who said no have 18.8. Those who said yes are 70.4. There are some that were unsure, as you can see. Diagnosis and infections, 74.3. Antibiotic treatment, 77.2. Again, they have been taught. And then there's the bit of being examined. Have you been examined on prudent use of antibiotics? 60.2. And as you can see, those who have been examined and those who have been taught on, it looks like it's a recurring theme as the data is showing. Whether they participated in student campaigns against antibiotic use, it's 18.0. And I know we usually have the Antibiotic Awareness Week in September. In November, I think. This is a gap because only 18 have ever participated in campaigns against misuse of antibiotics. We have, so next slide, participation on the prudent use of antibiotics, as you can see. So the no, those who say they never participated, it's 69.6, and that's a huge number. Yeah, how they were participating, you can see it's by rallies and campaigns, only 8 out of the 87. So again, there's a gap, not just in Kenya, but in the region. Yeah. Means of participation, debates, conferences. The one that was high was educating people on antimicrobial resistance. And this is, I think, it by the use of infographics, posting on their statuses and maybe on Facebook. Yeah. Teaching methods for prudent antibiotic use. We have lectures with more than 15 people. Next slide, please. Lectures with more than 15 people, which is 61.1. That's the highest method of learning. Yeah. This is just data that I'll just walk over because of short time. Next slide, please. Reference sources for information. Where do they get this information? Yeah, 47% did not know any source of information on antimicrobials. Yeah, antimicrobial stewardship awareness among students. It's important to note that 52.2 had no prior knowledge of the term antimicrobial stewardship. 42 stated they had heard of AMS, and 5.8 were unsure. So antimicrobial stewardship as an important subject was not mentioned. And this is, I know it's wide, and maybe the lecturers who are here, they never maybe communicate that, but there is a gap right there. Yeah? And what are the barriers of getting this information about AMS? Lack of resources, 50.6. Internet access, 29.8, but I don't think this one is affecting Kenya because our internet coverage is quite very well. Then we have some questions that were floated to the students, whether antibiotics are effective against viruses. Yeah, you can take a look that 24.4 thought antibiotics as effective against viruses. Antibiotics being effective against cold and flu, again, 36.4 thought they can be used to treat cold and flu. Yeah, you can see the various kind of gaps we have there. Yeah, but when you ask them, every person treated with antibiotics is at an increased risk of AMR. Again, there's 49.4. Yeah. Dr. Niz, I thought you are standing. I thought my time is up, so it's not yet up. Then let me just finish up. Level of agreement. I want you to look at the question highlighted. Prescribing, dispensing, or administering inappropriate or unnecessary antibiotics is professionally unethical. 65.2 thought it is unethical to dispense, prescribe antibiotics without a prescription. Another, next slide, some other data which is there available is it a recurring thing to learn about AMR in class? Yeah, only 14.7 said yes. No. They strongly agreed, but the ones who disagreed are 19.5 and 10.4. Again, there is a gap. Would you use an app that provides information? 35.6. My time is up. So we have again, next slide, different factors contributing to AMR. Yeah, not completing the full dose, inappropriate prescription. Those are the ratios, 36.6. I think there is a gap. So when they were asked, which topics would you want to learn about? Next slide. As you can see the data again, next slide, Mike. Yeah, those who wanted medical conditions for which antibiotics are used, it's 37.5. I think they are hungry for information. Next slide. Then we have educational tools that will be part. So the potential of using this app, there is data, as you can see, that they would actually use an app that you can download guidelines offline and use it in your practice. So in the discussion, what we noted is that, next slide, is that information is highly considered in universities. That is one. Various strategies are used in teaching students. That is two. But there are gaps again. Next slide. If, for example, this is the last slide. In as much as students have heard of antimicrobial stewardship, there are gaps that need to be filled because people who have never heard of AMS, it was quite a big number. People who have not participated in any antimicrobial resistance campaign, there was quite a big number again. But the study limitation was that it's only a few select countries that were used, and maybe the respondents was not, the sample was not as big, so that's the limitation. Yeah, so more concerted efforts can be used to align the curriculum with what is happening in the market today. Yeah, I'll end it there. Thank you so much, Dr. Aniz. We'll pick it from there. Thanks.
Thank you, Eric. Sorry to rush you, but now time is not on our side. Actually, it's on a serious note. Our schools, our universities, we need to up the game in their training. And I'm hopeful that we will find a body that will make sure that we up the quality of our training. Yes, boss.
Thanks, Dr. Aniz. Morning, everyone. Aniz, I want to read this so that members can also see what I'm reading, that I'm not making it up. In the last maybe 2 months, I've been getting SMSs from people who have been sent to me through colleagues. So they are not really entrepreneurs. You know the way the same people who do tenders wherever. So you know them, the big people. Yeah, they've seen an opportunity. There's a lot of shift in Africa towards local manufacturing. So a week, a month doesn't go, a colleague sends me someone who's looking to buy a manufacturing plant. Yeah. So this is one, I had been told about this guy, so he just reached out to me and said, I was to refer you by Dr. X to get in touch concerning buying a pharmaceutical factory. Can you assist me get one kindly? You know, ni kama ni bei ya jioni. Sindio? Yeah? Yeah, guys just want to do these things. Now, if we snooze, even that sector will be swept. This is a transactional lawyer who, just as I was sitting here, he's sending me a message. He's saying, Hi Louis, how are you doing? I have a client who is saying they are looking for a pharma production company for sale, very large one. We have a Moroccan company client who wants to buy one. The company size needs to be over USD.
Those numbers I don't know.
USD 150 million. Any ideas? I engage him, then I engage someone else. I engage a colleague who we usually need this. So he says, okay, thanks for sharing, Louis. This is specific. Is it Africa alone or Kenya? If so, there's none. If so, and there's no one else to advise, I can, but they have to engage my company to do that. You know, it's like you're giving someone, ndio hapa na mahali ya kununua company mzuri. See, it just needs to be a transaction. So I think I'm just trying to set the tone for, last conference you had me come talk about, we need to do, one of the resolution was we need to do a pharmaceutical manufacturing plant. We start from where the need is. So we've identified a need, we've identified a team, we have met investors, and there's a challenge that has been posed to us to structure ourselves in a way that is investor ready. Yeah. So my colleague, my respected senior Dr. Jane Masiga will come and just speak, then I'll just conclude.
Thank you very much, President. I'm Jane Masiga. Just to say something about myself is that for 30 years I worked with an organization called Mission for Essential Drugs and Supplies. Many of us know it as MEDS. And I just want to pride myself, at least there's always something you are first at. And I can record that I was the first non-expatriate pharmacist at MEDS. So 30 years back. At least I have a first in my record. So currently we stand at many pharmacists who have worked at MEDS and still working at MEDS. My colleagues, if you are here and you are pharmacists, please stand up so that we can know, at least we are talking of numbers. People who came after me, I know some of you haven't come. Yes, all those colleagues, the great ones, even have moved to other organizations. Dr. Aaron, Dr. Mwenda, we all work together. And in the process, we also mentored quite a number of pharmacists, and we know some who have grown to be managers. Pick them straight from the university and mentored them. If you are here and you are mentored straight from the university, just stand up. And now they are managers. Yeah, Isaac, stand. Yes. And now they are managers straight from university. Then we've also worked with Kenyatta University. Every year they used to send us students who would go through supply chain to know exposure to supply chain. And that pre-COVID, that is what we used to do. Just to say that when I joined MEDS, it was really unknown. It's an organization which was known. In fact, colleagues used to say, where do you work, MEDS? What is that? Who is that? So it was not known. Now at least MEDS is known. And you heard Dr. Sioi talking about yesterday and saying that he worked with me at one time. Yes, he's one of the people who I requested to help us set up quality standards at MEDS because then they were not really existent. So he wrote the first documents which we used, and I acknowledge him for that, Dr. Sioi. He led us to where now finally we are WHO pre-qualification, but he set the base for that. I'm sorry I have to talk very fast because the minutes are very short, but during the MEDS, my time at MEDS, we also had what we call local preference. So local manufacturers had local preference. In spite of that, we could not get all the needs we need within the organization. So we've traveled far and wide going to do GMP inspection outside the country so that we can get our essential medicines. During the COVID era, then the problem became even more highlighted because we could not even get things like infusions, water for injection. We also had to look for them to import them and get them into there. So when the president talked to me about this initiative, which is by pharmacists to start a local production, pharmacists to be there, to make a change in the country, to make an impact. I'm very excited. And I hope by the end of this presentation, which is very short, you will also be excited that pharmacists, not only can we complain, but we can change the landscape in Kenya. We can make a difference to the patient and to the industry so that we can at least make our own. This is disruptive pharmacy. This year or next 2 years, we should have some disruption in this industry. So that's why I'm standing here and just talk about the landscape. Where are we? Please turn the slide. Yes, the landscape. I won't talk much about the landscape because of the time which is there, but just to say that the farmer market down there is about $100 million. East Africa itself, we are not only targeting Kenya, even in East Africa, we don't have enough industries, about over $380 billion. So we really have a big market which we can stand on. Of course, we are talking about pharmaceutical, source of the pharmaceutical industries. You'll know that more than at least 25% is produced locally. Where is the 75% coming from? It's imported. So can we make an impact as pharmacists? That is what I want us to pick from there. Then state of the pharmaceutical supply chain. They are still just talking about that we do not have enough within the country. So the market is big and we can all share. Okay. So I'm going on to the part where is partnership. So we are looking of the opportunity. Please go to the opportunity. Yeah, the opportunity. So the opportunity we have is to start making IV fluids. IV fluids. What is in IV fluids? The biggest component, the volume. And water for injection, what are the major ingredients? Yes. So why should we be importing? So pharmacists, let us wake up and make a difference. So we are going to make our own IV fluids, and we start off, and this is going to be serving not only Kenya, but serving the countries around. So Kenya, the government of Kenya is already encouraging pharmaceutical manufacturing. Buy Kenya, make Kenya, buy Kenya, build Kenya. So we want to ride on that. I just want to look at predictability, the second bullet there. It says, who are the producers? So are we stepping on anybody? Yes, we have 3 out of the 6 East African producers of IV fluids are in Kenya. B. Brown, anybody representing B. Brown here? Yes, B. Brown is there. So you'll tell us more. That is only 20% of your production comes to Kenya, isn't it? And then we are going about Infusion Kenya Limited. I think we may not have representation. I don't know whether it's still working. Auto Sterile. So those are the people. So we are not stepping on any people's legs. We have a big market. We can't finish it. Then the partnerships, we are looking for partners who will be able to see this vision, that pharmacists can do something. Pharmacists can change the landscape. So those are the ones we want. So we may have a debt, we may borrow money, we may use equity, and equity means we as the stakeholders will chip in something so that we can get the money. And of course the banks are saying, what are pharmacists putting in before we can put in our money? Or we can put a combination of that, but we want a turnkey solution. Within another 2 years, we should be pharmacists employing all the new pharmacists and of course changing the market. So the projected, here I just want to look at the projected income, financing. We want 15.5 million USA shillings. And of that, the equity is 25%. The banks will give us 75% if we can raise the 25%. That is 3.8 million US dollars. Are we working together? Can we raise that money? I know we have the great people around here, plus the industries and all the pharmacists, respected pharmacists. So we can do that. And I may not be able to walk you through all the documents which we have, but just say that we are really raising and relying on you to help us. If we do that, just to show that we really worked through and thought through, is that by the end of year 10, the 5th year, would have a profit of 17 million. We'll be making a profit of 17 million if we do that. And the market is open. I know meds will be able to take our infusions, KEMSA will be able to take our infusions, so the market is open. So the implementation so far, a board has been set up. We have the implementation committee which is there. We have the clear implementation path crafted. We have key stakeholders identified. Even yesterday we were talking about banks. Banks are coming to us and banks are saying, can we work with you? Please join us so that we can be the next thing, the next kid in the block to be talked about. And then we have potential partners and advisors. These are the key stakeholders we've identified. If you find that there's any which we have not been mentioned, please let us know so that we add them there. We need to work together. All of us should work together. This is a project by pharmacists, for pharmacists. The next step will be to finalize on advisory and fundraising. We'll finalize on preliminary approvals, secure loan premises. We have already a piece of land, but we just want to do all the due diligence before we start. We want to book the equipment and look at the pre-operation expenses. I'll call the chairman to come and quickly go through. Please keep the pace so that we finish on time. Thank you very much for listening.
Makofia.
Please join us.
Yeah.
Be excited and join us.
Yeah. So that's the structure. One of the things when I go to the offices, so in this shareholding in this company, so it's a company with 1 billion shares, yeah? So, but no one pharmacist, a company that's a pharmacist can own more than 2.5% of the company, yeah? So that also we can have sort of equitable. But you see, the 2.5 also, it's quite an amount of money for you to own 2.5. So how the company is structured, it's a holding company. It's called Remedy Suppliers. There's a promoter, which is the investment company of PSK that holds the shares on behalf of PSK. Then now the strategic investor, someone who can give us maybe a big chunk of the cash, or we can match what we'll be able to raise, and financier. You may get a debt financier. So it will actually go as a consortium. Yeah, we'll be lucky if we get someone who, just one person who can finance everything. We've already spoken with investment companies, some of them state companies, who can give 500 million, that's $500 million. We have an advisory company that can get us access to $1 billion of what we need, then that means we have to raise 500. So the